Dear friends, in this lecture, I will try to discuss some of the cardiac complications of modern cancer therapy. And it's known that it's very clear that this is a vast subject, and I will only touch upon those pertinent areas which are relevant for the intensivist and with which the patient may come for an emergency admission requiring ICU care. So as usual, we'll go through the cases, and as we walk along these cases, we will pick up the relevant features and try to correlate with the diagnosis and the management per se of the critically ill patients. A 40-year-old male presented to the ER with dyspnea for a week and was intubated on the diagnosis of acute hypoxemic respiratory failure. The patient had received 3 cycles of cisplatin and doxorubicin after undergoing resection of the osteosarcoma of the knee, followed by TKR. The ejection fraction on echo was only 5 to 10% with severe biventricular failure. And despite all attempts for cardiac optimization, the hemodynamic status continued to decline. Patient could not be revived, and subsequently patient died on the second day. The autopsy, however, revealed no evidence of osteosarcoma, but only evidence of pulmonary congestion, liver failure, and multiple body cavity effusions, making it clear that the cause of this cardiovascular failure was not on account of malignant effusion or grade 4 malignancy, but it was the precipitation of this cardiac failure independently. So the probable cause of death was cardiac failure. So now what caused this cardiotoxicity? If not due to osteosarcoma per se, then what was the cause? We know that the range of cancer treatment has increased like never before. Earlier, mainly we used to consider surgery or chemotherapy or radiation, but now we have immunotherapy, we have hormone therapy, targeted therapy, as well as stem cell therapy. And all these therapies have very important role at certain stages of the particular malignancy. And sometimes the other therapies from immunotherapy onwards, they sometimes assume much higher importance than the conventional schemes of surgery, radiation, or chemotherapy. And moreover, personalized medicine has also changed the treatment plan of cancer in many ways. So the traditional model, which involved the diagnosis, the detection of the tumor, and the differentiation on the basis of metastasis, has been further expanded, and it now includes subtissue and metastasis, looking into the specific organ sites and the extent, the omics analysis, including proteomics, metabolomics, transcriptomics, etc., where those salient features that are characterize the individual pattern of that tumor in the specific individual can be recognized, the genetic mutations by identifying the receptors, and of course the personal factors, because there are a lot of individual variation in the progression of cancer and the kind of response and the extent of response to chemotherapy. And therefore, companion diagnostics which identify the specific treatments which would be most effective for a specific patients have become all the more important. So the novel therapies are used to target the cancer with minimum damage to the healthy tissues, and therefore personalized medicine or precision medicine is expected to make this model more effective and more safe. So when we look into the cardiotoxic effects of the anti-cancer drugs, we classify them based upon their structure, and we know that the anthracyclines are the most notorious agent, followed by the epidermal growth factor receptor type 2 inhibitors, that is the anti-HER2 medications, of which trastuzumab has been the prototype. The anti-metabolites like 5-FU, cytarabine, gemcitabine, methotrexate, hydroxyurea have a high potential to cause cardiac toxicities. The microtubule inhibitors and proteasome inhibitors, paclitaxel, docetaxel, etc., also have been incriminated in causing cardiac toxicities. The platinum-based chemotherapeutic drugs, cisplatin and oxaliplatin, have been known since ages to cause cardiac toxicity. But the most important ones, that is the angiogenesis inhibitors, which have given very good responses in certain malignancies, like the lymphomas and the leukemias, the bevacizumab, the ramucirumab, etc. They have been incriminated in causing a significant number of cardiotoxic events in such patients. So broadly, we classify the cardiotoxicity into either anthracycline type of cardiotoxicity or trastuzumab type of cardiotoxicity. Very broadly, for a clinician, these two types of cardiotoxicities can help delineate, because more or less the other toxicities will follow in either of the two patterns. Now, anthracycline toxicity can be characterized as either type 1 or type 2 based on the effect of these agents on the cardiomyocytes. The type 1 cardiotoxicity is caused by cardiomyocyte death, either through necrosis or apoptosis, and hence it is not reversible. That is, after cessation of the treatment or stopping the drug, it does not restore back to normalcy. Type 2 cardiotoxicity is caused by cardiomyocyte dysfunction. So there is no cell death, and therefore it may become fully reversible once the drug or treatment is discontinued or stopped. In both cardiotoxicities, there are certain risk factors like the extremes of age, female sex, hypertension, and pre-existing heart disease. If there is mediastinal irradiation, if there is treatment with simultaneous treatment with cyclophosphamide, paclitaxel, trastuzumab, etc. So in all those cases, the cumulative anthracycline toxicity increases, the dose of the anthracycline increases, and there is higher risk of toxicity. So largely, this anthracycline toxicity is because of the generation of free radicals, which leads to the mitochondrial redox cycling in the cardiomyocyte that results in LV dysfunction, and in more severe cases followed by congestive heart failure. Now the question arises how to prevent and treat this anthracycline cardiotoxicity. One is the use of pegylated liposomal doxorubicin that has been shown to reduce the cardiotoxicity over normal doxorubicin, and that is being used by the oncologists at a greater degree. Of course, the cost is sometimes a hindrance. And carvedilol have been shown to protect against doxorubicin-induced LV dysfunction through its antioxidant properties. Dexrazoxane, which is an iron chelating agent, has been shown to reduce the incidence of congestive heart failure and also decrease the fall in the ejection fraction in these patients. Enalapril prevented the late decline in LVEF in patients with elevated troponin I values during the doxorubicin treatment. So these patients had some component of vascular compromise also, which was characterized by elevated troponin. So they got benefited. So we can say that treatment with either ACE inhibitors with carvedilol should be considered in patients who are at risk for developing anthracycline cardiotoxicity, particularly those who have fallen under those risk factors, in whom pegylated liposomal doxorubicin is not used, and in whom high doses of doxorubicin are used. So in all such patients, this regime can give some protection. Coming to the second case, a 60-year-old female presented with chest tightness, shortness of breath, and nausea for a day. Troponin was insignificant, hemoglobin was normal. Patient was a follow-up case of CA esophagus, and post-esophagogastrostomy received cisplatin, 5-FU, and radiation, followed by Folfox. Folfox is a combination of folinic acid, 5-FU, and oxaliplatin, and trastuzumab. The Folfox was given every 2 weeks, and the trastuzumab was given every 3 weeks for 6 months. Now, in ECG, the patient developed fresh changes. There were new anterolateral T-wave inversions. You can see all these T-wave inversions are visible. They are very prominent here, particularly in V3, V4, AVF. Now, 2D echo showed new anterior and anteroseptal wall motion abnormalities with an ejection fraction of 40%. So the fall in ejection fraction is not substantial in contrast to the anthracyclines, but the changes in ECG are very much prominent. Now, what is the cause of this cardiotoxicity? Again, the trastuzumab, the patient has been incriminated as a very important cause of cardiotoxicity, and various studies have found various incidents, but in one study which had a large number of patients. There were 3-year cumulative incidence of 35% of cardiotoxicity, which was defined as more than 10% decline in the ejection fraction and less than 55% without symptoms, or more than 5% increase in fall in the ejection fraction with less than 55% with symptoms in at least one Muga scan. And this was found to be in HER2 positive breast cancer who had received more than 12 months of trastuzumab therapy. The others have also found to a different magnitudinal level the incidence, but in any ways, one thing remains that trastuzumab induced cardiac toxicity was very high. Now, trastuzumab is often given as adjuvant to anthracycline treatment, and in those cases, the cardiotoxic effects are even more amplified. So the cumulative incidence of this effect as compared to the anthracycline only treatment is higher. So what is the treatment for such trastuzumab-induced cardiotoxicity? Because the guidelines recommended at least temporary discontinuation of trastuzumab therapy if significant decline in LVF is detected by monitoring either symptomatic or asymptomatic patients. Again, ACIs or ARBs and the beta blockers are the first line agents. Then these are followed by loop diuretics, hydrolysine nitrates, aldosterone antagonists. All of that follow the AHA guidelines and the ACC guidelines. But the newer agents have also shown to have benefit, particularly the neprilysin angiotensin receptor antagonist, that is the sacubitril valsartan, and also there is role of ivabradine. However, for advanced heart failure, the cardiac resynchronization therapy, mechanical circulatory support, and even in extreme cases, heart transplant may be considered and may offer some benefit. But the data are scant pertaining to the impact of the traditional heart failure treatments in patients who develop cardiotoxicity from trastuzumab. So these guidelines, which have been made, have made recommendations from trastuzumab, have tried to take salient features and points also from anthracycline-based toxicity, also knowing it well that the two are exactly not similar, but the management of cardiac failure would be similar on many accounts. Let us go through the third case, which is a 48-year-old female with CS cervix stage 2B, no CVS risk factors, was admitted for concurrent chemoradiotherapy with weekly carboplatin plus paclitaxel with radiotherapy, external beam radiotherapy, and intracavitary therapy. After completion of the first cycle of paclitaxel infusion, the patient presented with diaphoresis and decreased consciousness levels. On examination, the patient had bradycardia, hypotension. Saturation was still normal. There was ST elevation in the leads 2, 3, in AVL, AVF, V5, V6. In fact, there was both changes in the inferior and the lateral leads. So what was the cause of this cardiac toxicity? Now, platinum-based chemotherapies have already been known to cause direct myocardial damage, and which can manifest as reduction in the ejection fraction, heart failure, and importantly, it can also present as acute coronary syndrome. Because another key aspect of platinum-based chemotherapy is vascular toxicity, which leads to endothelial dysfunction and arterial hypertension, and this contributes to the exacerbating risk of thromboembolic events and ischemia. Moreover, electrolyte imbalance, particularly that of magnesium leading to hypomagnesemia, is another concern, and therefore platinum-based therapies often lead to arrhythmias and cardiac complications, which are not directly as a result of the cardiac effect, but because of the hypomagnesemia producing such an effect. One important thing has been found that in such therapies, supplementation with lactobacillus can significantly counter the negative side effects of cisplatin and lead to an increase in the body weight and restoration of the cardiac function. Coming to the case 4, a 76-year-old male presented with dyspnea and altered mentation for 2 days. Patient had a history of large B-cell lymphoma, which was diffuse, and patient was treated with CART therapy. His FDG PET scan performed a week before the CART therapy showed enhancement of numerous abdominal nodules with skeletal involvement. His baseline cardiac workup showed no structural abnormality on 2D echo with a normal ejection fraction. 12-lead ECG showed normal sinus rhythm without any STT changes or Q waves. Baseline troponin I and BNP were normals, but he experienced grade 2 CRS on day 7. and with fever and hypotension, for which he received tocilizumab. The cardiac magnetic resonance identified acute myocarditis based on pericardial gadolinium enhancement. Now again, the question comes in CART therapy, what causes cardiac toxicity? Now, the CART cell cardiac toxicity has been found to occur in 10 to 20% of the patients who develop high-grade CRS after CART cell, and that includes cardiomyopathy, heart failure, arrhythmias, and MI. So their risk factors includes the CRS grade 3, that is any grade of CRS 3 and above, old age with coronary disease, high lipids, aortic stenosis, altered kidney function such as high creatinine as well as high troponin at the baseline. Several heart complications associated with this therapy includes hypotension, LV dysfunction, and shock. And the Juliet trial, the Zuma 1 trial, the Zuma 2 trials, all on CART therapy have clearly demonstrated LV dysfunction, cardiac arrest, or cardiac failure. That is cardiac failure followed by cardiac arrest. Now, multiple retrospective studies have also tracked the cardiotoxicities and reported tachyarrhythmias, cardiomyopathy, and pericardial effusion. Now, how to monitor for CAR cell therapy cardiotoxicity? Now, patient has to be monitored on days 0, 3, and 7 from the infusion of the CAR cell therapy. If CRS happened is grade 1, then no further heart monitoring is required. If the CRS is 2 or above, the patient's troponin should be measured daily, along with measurement of NT-proBNP on alternate days or on days 0, 3, and 7. Telemetry monitoring continuously with TTN and stain, and the patient needs a follow-up for a period of 1 month. And in patients, all patients with a CRS grade 3 and higher, they need cardiac follow-up every 3 months. So the occurrence of CRS is a very important risk factor as far as cardiac toxicity is concerned. Patients with reduced baseline ejection fraction have a trend towards higher all-cause mortality. In addition, the elevated high specific troponin T during the first 2 weeks and infusion also may be associated with a high mortality. Here we want to try to find out what is the difference between CAR therapy and immune checkpoint inhibitors, because for non-oncologists like us, we tend to use them irreplaceably, that the two things are distinct. CAR cell therapy elevates the immune system cells against cancer, acting on T cells and natural killer cells, which are the body's primary defenders, but they often fail in locating and killing the cancer cells. The critical side effect is the CRS. The immune checkpoint inhibitors block the cancerous protein actions on either cancer cells or fighter T cells. The cancer cells have masking protein receptors that can trick the T cells into leaving them alone. So that portion they overcome, the immune checkpoint inhibitors overcome by neutralizing this protein receptors. Now, nowadays, many such therapies have combined CAR cell and immune checkpoint inhibitors, and there appears to be some merit to the idea of using the two forms of immunotherapy to make the cancer cells more vulnerable to the immune system. So therefore, they are often being combined now. Now, if you look into the profile of cardiovascular toxicities of this immune checkpoint inhibitors, we see that they can range from the atrial fibrillation by supraventricular tachycardia, VT, heart block, that is those involving the electrical circuit, to pericarditis and pericardial effusion, that is involvement of the pericardium, involvement of the vessels leading to coronary artery disease, temporal arteritis, cerebral vasculitis, polymyalgia rheumatica, etc., or involvement of myocardium leading to myocarditis, heart failure, cardiogenic shock, Takotsubo's cardiomyopathy, and so on. So each and every component of the cardiovascular system is actually predisposed to the effects of the toxicities of the immune checkpoint inhibitors. Although myocarditis is the most common and most fatal, and high-dose corticosteroids are the mainstay of management, and they should be also guided by the severity of adverse events, because if the events are mild, then they should be tapered early. The question is how to monitor them using the imaging modalities. Now, depending upon the modality used, echocardiography, Muga scan, cardiac magnetic resonance, or cardiac biomarkers, they all have their distinct advantages and limitations, but there are certain findings which are classical for each one. Like in Muga scan, an LVF decrease of more than 10% with a value of less than 50% indicates that there is definitely cardiac toxicity, which has been precipitated by the drug. In echocardiography, if the reduction is more than 10% to a below lower limit of normal, or a reduction in more than 15% from the baseline, so in that case, it is possible to understand, that is, if there is a global longitudinal strain is more than 15% reduction from the baseline, then we will have to suspect this too. There are similarly specific findings for cardiac magnetic resonance and cardiac biomarkers. And but the problem with cardiac biomarkers is that their major limitation is undefined role in routine surveillance. So therefore, they are not always adhered to, although they are widely available. If we want to grade the severity of the CRS and accordingly try to see their effect on the cardiotoxicities, it is important because the grading determines on holding or permanently discontinuing the IC inhibitors. That is, if the grading of severity is G1, we can hold the immune checkpoint inhibitors. In 2 and 3, we have to permanently discontinue the immune checkpoint inhibitors. When it is grading is G4, not only we have to permanently discontinue, but we should also follow it up with a methylprednisolone IV of 1 gram per day for 3 to 5 days. So this, of course, should be monitored with the continued steroid during the cardiac function returns, etc. So if you see the nature of the anti-tumor drugs, you will realize that for trastuzumab, the ejection fraction decreased without symptomatic, without asymptomatic, about 40% after therapy for 7 years. But the protection can be offered by perindopril, bisoprol, that is AC inhibitors and beta blockers. We look for the biological markers, echocardiography, as well as the cardiac magnetic resonance, besides, of course, ECG. For anthracyclines, again, the potential for cardiac toxicities are much higher, including congestive heart failure, arrhythmias, which also carries a high mortality. Again, protection is offered by dexrazoxane, NKIR1 blockers, and the ACE inhibitors. There, the monitoring with biological markers, echocardiography, cardiac magnetic resonance, and the ECG is in the same way as it is for others. For immune checkpoint inhibitors, they progress to multiple organ dysfunction, and that multiple organ dysfunction is the main cause of the mortality, alongside fulminant myocarditis, which occurs in around 1% of the cases, and protection is conferred by the use of corticosteroids. The markers for monitoring the echocardiographic findings and the cardiac magnetic resonance in ECG are similarly important for their surveillance. So the common monitoring techniques, which are equal for all kinds of cardiotoxicity after cancer therapies, include those based on serum markers, those based on ECG, those based on echocardiography and cardiac magnetic resonance. So for an intensivist, a knowledge of the serum biomarkers, ECG and echocardiography would suffice in most cases. And the suggestion should be combined with imaging with serum biomarkers. With ECG and they can be on for routine inspection. So although echo is considered as the routine test for cancer patients to monitor this cardiotoxicity, the recent studies have also shown that the ejection fraction measured by cardiac magnetic resonance has the highest repeatability compared with that measured by the 2D echo in patients with cardiotoxicity due to cancer therapy. So my final take-home message would be that the manifestations of cardiotoxicity due to cancer treatment includes heart failure with reduced ejection fraction, arrhythmias, thrombosis, hypertension, ischemia, myocardial infarction, that is all the manifestations of ACS. The mechanisms behind these effects have largely focused on oxidative stress, calcium overload, and direct toxicity leading to cardiac tissue death. The incidence of chemotherapy related cardiac toxicity is influenced by several factors, including specific pharmacological therapy, duration, age, sex, and the underlying disease conditions, particularly presence of coronary artery disease. The standard gold treatment for anthracycline-induced cardiotoxicity is dexrazoxane, although for prevention, AC inhibitors and beta blockers are the most helpful. The non-pharmacological approaches like early detection techniques and lifestyle interventions can help prevent or reduce these risks to a significant degree. Thank you very much.